Right, so today I prepared a bit of a discussion around home inductions for buprenorphine as part of office-based opioid therapy. Want to again acknowledge the support from SAMHSA and DHS for our ECHO session, and I don't have any relevant disclosures here. So what I want to get to in our remaining few minutes is just really quickly revisit some of the precepts that are seen as the guidelines around induction, and then talk a little bit about observed or office conducted inductions as opposed to home inductions or unobserved inductions, as that's getting to be a more common practice. Talk a little bit about theoretical pros and cons of the approach, what some outcomes in the literature have looked like, and what, based on my review of this topic, looked to be some important clinical considerations related to the practice. So first off, what are our goals during the course of induction? Well, of course, we want to relieve opioid withdrawal symptoms. Opioid withdrawal is a horribly uncomfortable and negatively reinforcing state to be in, and we want to relieve that as promptly as we possibly can. Reducing opioid craving, and of course, reducing illicit use and improving function down the road after the induction takes place. All right. We, of course, want to avoid adverse effects during the course of the induction. Probably the most seriously feared by patients and providers alike is the risk for precipitating opioid withdrawal if buprenorphine is administered too early. During the course of assessment and induction, we also want to set the tone around the structure for follow-up and monitoring, and establish a healthy rapport and develop a therapeutic alliance that will hopefully, in addition to other plan components, keep the patient in treatment. That's really a primary goal, because more is generally better in this situation. A question becomes whether all these things can be done with an unsupervised induction, or whether there are advantages to the office-based induction. And I'll be talking a little bit more about what these two frameworks look like and advantages and disadvantages. So guidance typically on inductions through a number of guidelines through SAMHSA and ASAM, among others, involve some of the following. And I find this first one fairly useful, is talking to folks about their typical withdrawal course, what symptoms they expect, when they expect them to arise. That's fairly variable inter-individually. So having conversations with patients about what that looks like for them can be helpful in terms of anticipating what an induction course will look like for them. And some of these guidelines will actually even encourage, if a patient can't give you that sort of history, what's called an abstinence challenge, where with the support of some adjunctive pharmacotherapies, you sort of ask them to go a period of time without using, so they can develop a sense of what this course might look like if it's something they have difficulty characterizing. In addition to this being an individual process, it'll depend to some extent on the substance that they're most typically using and have used recently, so far as when you might expect symptom onset. And so I've put on this slide some of the typical examples of substances and course in terms of number of hours after last use and when you expect to see early symptoms. When to start buprenorphine? Again, these substances that are typically misused and for which folks will develop use disorder are full opioid agonists. So they go to the mu-opioid receptor and turn it on fully, creating the typical effects where buprenorphine has a very high affinity for that mu-opioid receptor, but is also a partial agonist. So when you give someone a partial agonist with that sort of receptor affinity who currently has opioids in their system to which they're physically dependent, you put them into immediate and horrible withdrawal. And so they need to be in some degree of withdrawal before the buprenorphine gets started in order to prevent worsening that situation. And exactly where that should be and what that should look like varies a little bit depending on which guideline you read. There's a specific scale for the severity of opioid withdrawal called the Clinical Opioid Withdrawal Scale, or COWS, and different guidelines will recommend that score being at least 11 or at least 6. And I think my next slide, yeah, this is the scale for those of you who aren't familiar with it. So you can see the different anticipated withdrawal symptoms and the sorts of scores that each category can generate, and where a total score of 5 to 12 indicates mild withdrawal, 13 to 24 moderate, etc. And so then we give an initial low-ish dose of buprenorphine in the office. Then the patient is observed for an hour after that dose, and then it can be repeated during the course of that day to achieve stability, with the recommendation being that the maximal dose on day 1 be no more than 16 milligrams. And so that's generally what that looks like when we do it in the office. Conduct the assessment, monitor for moderate withdrawal, provide the medication in the office, and observe and ensure symptom relief and tolerance of the dosing. And doing this in the office allows for us to ensure that they know how to take the medication, that they're in fact taking it sublingually, they're letting it absorb, and they're not swallowing it, for example, in which case it won't be effective. Can enhance the therapeutic relationship. When a patient is in opioid withdrawal and they are given the relief that buprenorphine provides, they are quite appreciative, and those are some really rewarding office visits. Allows you to verify that in fact they're in opioid withdrawal. There can be some education that takes place between doses if they are spending this time being observed in the office, and you can also make sure that they aren't having evidence of sedation. Say, for example, in the case presented today where the individual had a history of misusing sedative hypnotics, and you can observe and make sure that there isn't that sort of interaction or risk. So what about doing this unobserved, or having the patient take a limited supply of buprenorphine home and giving them appropriate education to conduct this induction in that environment? Why might we think about doing that? Well, one is the travel time and inconvenience potentially related to travel. Driving is discouraged after taking the medication, and whether or not driving to the clinic might be impaired by the withdrawal syndrome itself really isn't known, but is certainly theoretically possible. There are challenges around the office induction, as those of you who have done it know, and those hearing it described would probably intuit. Again, there's concern around potentially precipitating withdrawal, and how do we handle that in the office? Patients being in active withdrawal in the waiting room and the discomfort that that causes for the patient themselves, as well as potentially sort of concern and discomfort on the part of other patients in the waiting room. Having the medication on hand in the office also comes with some logistical and regulatory challenges that those unfamiliar may feel quite daunted by. And I've already mentioned some of the issues with waiting area logistics and anonymity if someone is in active withdrawal. So some advantages of unobserved or home-based inductions: less office time and staff time taken up. Patients may actually prefer the comfort of their own home. And that practice, just in terms of how things are typically done in general medical settings, is more in line with ambulatory prescribing practices. So what's been happening so far as this goes up to now? This has become quite a widespread practice, and we know that based on surveys of waivered physicians in a number of states. I'm just putting up examples of a couple of those. By way of what's happened in terms of structured research, is actually fairly scant and is primarily observational. But what is out there appears to indicate that the complication rate is indistinguishable between office-based and home-based inductions, which was the case with the one randomized controlled trial on this that's out there. The one thing where they did see some increase for the home-based inductions was more prolonged opioid withdrawal symptoms. Those were generally mild to moderate, but someone doing the unobserved induction was less likely to have their symptoms completely controlled as early as the office-based folks were. And when we say home induction, what are we talking about in broad strokes by way of how this is carried out in typical practice? Of course, a thorough assessment and appropriate laboratory testing based on their history and risk factors, including liver function, urine testing, and having infectious disease risk on the radar, of course, important by way of hepatitis, HIV, and the like. And depending on the setting, thinking about patients that might be most appropriate for this, and whether the provider has the experience and comfort level to be able to do it. There's still a preparatory office visit, of course, where these assessments are done and where education is done by way of managing early withdrawal symptoms prior to the induction itself, and by way of discussing the follow-up, which should be done during the course of the induction. But in the case of unobserved or home-based inductions, on day one is primarily over the phone. Provide a prescription and guidance for using medications that can relieve some of the withdrawal symptoms, including clonidine, adjunctive medications for the nausea, abdominal discomfort, potentially diarrhea, things along those lines, and instruction around the dosing on that initial day. Again, very important to follow up. I talk to patients, and this is where, as I was talking about earlier, it's really helpful to have a clear sense of what a typical withdrawal course looks like for a patient. So that you have a shared understanding of when they might expect to be able to take that first dose of buprenorphine, so you can make that telephone contact, see how it's going, and make sure that they're tolerating that first dose and that they're in a place where a second one might be reasonable. There are subjective opioid withdrawal scales that have been studied for use in the setting of home-based inductions. So this is something the patient can take home and that they can score on their own, so that they have an even clearer sense of when they might be able to take that initial dose of buprenorphine, and they ought to be getting at least close to that moderate withdrawal score range before considering taking that initial dose. Though, as I say, some guidelines and some studies have had patients initiate even sooner. Some of us, myself included, tend to err somewhat on the conservative side, because we do know that the buprenorphine administration is more likely to go more smoothly, and there's lower likelihood of precipitated withdrawal if they are able to hold out that little bit more. You certainly don't want to push it out so far that they're at risk for or feel compelled to use opioid other than the buprenorphine. But so there's a little bit of a balance there, but most folks can tolerate with the relief you provide with those clonidine and other medications to get to that moderate range anyway. And that was the score on this scale that was used in that randomized controlled trial. So they even pushed it a little higher than that low moderate range. So as I was going through this, these were some of the things that I saw as being out there in the literature, and again, in a pretty common community practice these days. Home induction is feasible, it's highly prevalent. The evidence, though, is probably not adequate to tell us precisely the success rates of office-based versus home-based, but as I mentioned, there are certainly some theoretical reasons to think about it in particular patients, and the more recent updates on the guidelines around buprenorphine prescribing in offices do acknowledge this as an option, though they still recommend considering the office-based induction. And they also recommend that the provider considering the home induction have a certain amount of experience of office-based inductions before pursuing this practice. How many should that be is not well defined. A thing to keep in mind for those considering taking on this practice is if there is precipitated withdrawal or a complicated induction, that makes it more likely that those patients are going to have a more difficult time sticking with buprenorphine and medication-assisted treatment. So it's important to keep these points in mind and be careful about the induction, talk to patients, get a clear sense of what their withdrawal course might look like, frequent communication during the course of the induction day if it's at home, to make sure that those sorts of adverse effects don't interfere with the likelihood that they're going to stick with treatment. Some other things just to keep in mind by way of issues that increase the likelihood of more complicated inductions and where you might want to think about an office-based protocol being preferable. Methadone use, quite long-acting, and we know there's greater likelihood of that precipitated withdrawal if methadone is the primary substance used. Recent sedative hypnotic use. As I mentioned, the office-based induction gives you the opportunity to observe folks after the buprenorphine dosing and make sure that sedation is not an issue. These days, you know, another thing that I come across a lot is a lot of folks with opioid use disorder already have experience with illicit buprenorphine. So that's another thing to talk to people about. And if they've had their own experiences and they know what to anticipate and when to self-administer the buprenorphine, I find that reassuring and also might be more likely to consider a home induction. The other thing we know is that it's important to get withdrawal symptoms under control quickly. And so the other thing that's been a factor associated with lower likelihood of treatment retention is if the induction dose is too low. So with home inductions, we'll tend to start off with more like 4 milligrams as an initial dose that gets folks closer to better control. But you know, with office-based induction, sometimes we'll want to start lower. For example, if we're unsure about methadone or benzodiazepine use, and then those lower doses are somewhat lower risk for creating a precipitated withdrawal that's more severe and problematic. So that's what I have today.